So the final presentation in this session will be Xin Liu, who will be discussing the breast-length tazobactam in pelvic exenteration. Please.
Yeah, I'm going to present our POP-PK study of the PIP test in patients receiving elective pelvic exenteration surgery. This surgery is a long radical abdominal procedure to remove the pelvic organs used to treat cancer of reproductive organs. And the most common complication for the surgery is the surgical site infection. Piperacillin and tazobactam is given before the surgery to prevent this type of infection. But due to the hemodynamic and perfusion instability in patients that's caused by the intensive blood loss, volume resuscitation, and fluid shift, the pharmacokinetic behavior of the antibiotics could change. Therefore, we performed the study to understand the PIP test behavior in these patients and try to provide the dosing recommendation for optimized intraoperative antibiotic exposure. There was a prospective open-label PK study performed in Royal Brisbane and Women's Hospital, and the recommended dose of the PIP test was given before the surgery and by the intravenous infusion over 30 minutes, and that was redosed every 8 hours for the prolonged surgery. And the population PK analysis finally was performed in the Monolix software. Here's the summary of the patient information. In total, 12 patients was included in the study. Median age 49.5, median weight was 79 kilograms, and none of them show the severe impairment in the renal function as shown by the EGFR value. And here shows the observed plasma concentrations, intensive sample collected in 2 occasions. The final PK model was a 2-compartment model with the between subject variability and the inter-occasion variability estimated for some of the parameters. And during the covariate analysis, we found the body weight and the EGFR contribute significantly for the clearance for both drugs. This was reported in the literature already. The new thing we found in this study is the total fluid received during the surgery can affect the central volume distribution of the piperacillin. So here's the summary of the population PK parameter estimates. All these values were comparable with the literature, and our bootstrap data also confirms the stability of the model. We also use the goodness of phase plots and this zero predict check plots to validate the model. Once the model was validated, it was used to simulate piperacillin plasma concentration for different dosing regimen. And the target was set to maintain the piperacillin concentration, unbound concentration above the MIC of 8 and 16 mg per liter for the whole duration of the surgery. And it was obvious from this figure, the original dosing regimen could not achieve the target, and using the same dose, but instead of infusion over 30 minutes, change to continuous infusion could improve the exposure, but adding the loading dose could achieve the PTA over 90% for both MIC values. So we also evaluated the covariance effects basically for the same dosing regimen with the increased body weight, EGFR, or the fluid volume. The clearance or the volume distribution will increase, then the plasma concentration will be decreased. So in conclude, we found the continuous infusion maintains the drug concentration above the MIC for longer time compared to the repeat bolus injection. And the patients with the larger body weight and faster EGFR or receiving larger volume of intraoperative fluid will have a high risk of the inadequate antibiotic exposure. I'd like to acknowledge all the co-investigators. Thank you.
Thank you. It's a nice example of how all of this work is also relevant for intraoperative antimicrobial dosing, which may be not in the comfort zone of many of us. So I think this was the last presentation in this session. I have to thank the speakers for staying within the 7 minutes range, more or less.